turn the program over to Dr. Gray, who we all came to hear tonight. And you can give us your bio. Thank you.
Well, thank you, Elizabeth. And thank you all for coming. And it's a little smaller group than sometimes, which is just fine. And it can be a little more personal that way. So if you have questions or thoughts, I'm really a teacher's kid. My mom taught special ed. My dad taught music. So I like to teach more than speak. I can speak if I have to, but I prefer to teach. So this can be a little less formal with a smaller group. So if there's questions or thoughts as we go, just raise your hand or interrupt, and we'll just kind of have a conversation. I just finished 28 days of call. I work actually just in Hickory. I'm a hospitalist, internal medicine. So I just do hospital medicine and critical care. And I just finished 28 days of call so I could free up time to go on the road. I'll be traveling with Patsy in the back. Patsy, I think most of you got to meet her. We'll be heading to Chapel Hill and Durham, and then up to Pittsburgh to speak up at Grove City College and some spots in Pennsylvania, and across to Delaware in about a 2-week tour. So, and then coming back here. Because this is such an important sort of time for our country when we're sort of trying to decide which of two futures to follow. And a lot of this is going to be driven by health care. So what I'll try and do tonight is give a sense of the bigger picture. I mean, this health care bill at 2,700 pages is enormously complicated. And there's probably nobody that actually really understands the thing. And part of the reason nobody really understands it is because even though it's 2,700 pages long, it really doesn't say what's going to happen to health care. Most of it transfers power to the Secretary of Health and Human Services, giving the Secretary of Health and Human Services the ability to write what's going to happen. They've already written about 10,000 pages of regulation, and it's that regulation that's going to determine what health care is like, not the initial bill. So even if you memorized all 2,700 pages of the bill, you still wouldn't understand what's going to happen, because it doesn't say. All it does is transfer power. So we'll get to that in just a bit.
One man is doing this?
Well, there's this, at the moment it's Kathleen Sebelius. So it's a woman, and she'll probably be secretary for another year or so, depending on what happens in November. And then depending on the courts, and we can talk about that some too. But let me back up and just start to put this all in context. Right now, the U.S. debt stands at about $10.7 trillion. That's the public debt. Our total U.S. debt is about $15.6 trillion. That's an awful lot of money. Just the interest on this debt. Right now we're paying somewhere around 2.25% on our debt. So this is about $240 billion a year that we're paying on interest. But 2.25% is a historically low number. If you go back to the 90s, the average interest rate was more 5%. So if we return to the average rate of interest, we're going to be paying somewhere around 535, or if it's 5 to 6%, we could be paying as much as $642 billion a year just in interest on our debt. Now the CBO has estimated that debt is going to almost double in the next 10 years if we don't do something about federal spending. So if you double this number, we're looking at $1 trillion+ a year just to cover interest on the debt. And that's unsustainable. As a nation, even though we're enormously wealthy, have a huge GDP, we can't sustain $1 trillion a year just to pay interest on our debt. There's supposed to be a couple other numbers in there, but just for comparison's sake, the total cost of Medicaid is about $427 billion a year. So we're starting to approach where just the interest on the debt rivals Medicare spending or Medicaid spending. That's a huge, huge number. So that's one concern. A second concern as we look at healthcare is there's this recent survey, it was just done at the end of February, said 43% of physicians might retire in the next 5 years because of the Patient Protection Affordable Care Act. And several of you are seniors, you're starting to have more difficulty finding a physician, where fewer physicians are taking patients on Medicare. And even if you've had a physician, sadly there are some patients when they reach 65, they go in and see their physician. Their physician will tell them, I'm sorry, but I'm not going to be able to continue to see you. So not only are we losing the ability for physicians to take care of patients on Medicare, we're going to be losing close to half of our physicians. That's a little bit overstated. Here it says, the question is healthcare reform likely to make you retire in the next 5 years? Very likely 23%. Those are the folks planning on getting out in the next 5 years. Somewhat likely another 19.2%. I doubt all 43% are going to leave medicine in the next 5 years. A substantial number of them will. So as hard as it is for seniors to find physicians now, it's going to become significantly worse. And another question I had is, would you recommend healthcare as a profession? And it says 9 out of 10 physicians are unwilling to recommend healthcare as a profession. It used to be, back when I was a kid, I decided to go into medicine in about 4th grade. And physicians wanted their children to go into medicine. It was a good profession. You could help people, it was a steady job, and it was something people aspired to do. Most working physicians now would say, boy, how can I escape? So most docs are thinking of how do they get out of medicine, not trying to get the best and the brightest of the kids to go into medicine. So we're looking at a culture, American culture, where we're going bankrupt. And as it applies to healthcare, we're losing our physicians. And not only are we going to lose our physicians, we're losing the kids that should be going into medicine. So something is dramatically wrong. So the question is, how do we reach a spot such as this? What does it mean for patients? What does it mean for physicians? Then what does it mean for our future? And can we take another path? So that's sort of what I'm going to talk about today. When I first started this was back in the mid-1990s, and I'd read a book by Peter Singer, and it's called Rethinking Life and Death. How many have heard of Peter Singer? So he's a chair of bioethics up at Princeton, pretty important guy. And he said to reduce the rising cost of healthcare, we should redefine human life. So instead of human life beginning at birth, he said, well, let's not count infants, quote, fully human until they reach the 5th week of age. So if an infant is born with a disability, they could be killed or put to sleep. And the idea is if we don't have kids with disabilities, we don't incur all those expenses. So if we take expensive kids and put them to sleep, we can take that money and spend it on more gifted kids, and it makes for a much more efficient form of practice of medicine, much more efficient, productive culture. So I asked, how did one of our leading bioethicists, this is a guy of national influence, how could one of our leading bioethicists actually advocate infanticide as a way to reduce the rising cost of healthcare? So I went back and read some 50 or 60,000 pages of history and philosophy, and I found these remarkable, remarkable patterns. And that's a story I'll tell you now, just how we got to a place such as this. Actually starts back with 2 thinkers, Plato and Hippocrates, and they were contemporaries in ancient Greece. Plato states in his Republic, but bodies that disease has penetrated through and through the physician would not have attempted to cure. He did not want to lengthen out good-for-nothing lives or to have weak fathers begetting weaker sons. If a man was not able to live in the ordinary way, he, being the physician, had no business to cure him. For such a cure would have been no use either to himself, or note these last 4 words, or to the state. Here we see Plato, this is back in ancient Greece, 2,500 years ago, saying the role of the physician is to look out for the welfare of the state. If it's good for the collective, if it's good for society, the physician was to choose to treat the individual on that basis. So the physician wasn't looking out for the well-being of the individual patient. Plato goes on. These practices will treat the bodies and minds of your citizens who are naturally well endowed. As for the rest, those with poor physical constitution will be allowed to die, and those with irredeemably rotten minds will be put to death. So here we see Plato saying the ideal physician was to choose people in society that are young, that are strong, that are fit, that are moving culture forward, that are moving society forward. And those that are a quote, burden on society, the physician wouldn't take care of. So this started to resonate with me in terms of the thinking of Peter Singer. You know, if that deformed infant was a burden on society, would either kill them or let them die. What Plato is saying here is very, very similar. As opposed to this, we have another contemporary of Plato's in ancient Greece, Hippocrates. Plato was born about 427 BC. Hippocrates was born about 460 BC. Hippocrates takes a very, very different role on what it means to be a physician, what it means to be a patient. Here we see him talk about the genuine care for the patient. On Ambrose he writes, quote, "The physician sees terrible things and touches on the lonesome, and from others' misfortunes harvests troubles of his own." So here we see a very different meaning of what it is to be a physician. So instead of the physician looking out for the patients that are young and strong and can go back to work to move society forward, Hippocrates says, I'm going to devote myself to the individual person. And even if they cause me misfortune, I'll reach out to them to help take care of them. He talks about the sanctity of life in his Hippocratic oath. He says, quote, "I will not give a poison to anyone though asked to do so, nor will I suggest such a plan. In the same way, I'll not give a pessary to a woman to cause an abortion." Now look at this last sentence. "But in purity and in holiness, I will guard my life and my art." The first sentence, "I will not give a poison to anyone though asked to do so." In ancient Greece, they had trouble with pain control, much as we do today, except it was much worse then. So if they had a patient with a metastatic cancer, or a pinched nerve, or a severe fracture or something, this kind of relentless pain, sometimes that patient would go to the physician and say, "Can you give me something to end my life? Let me escape this pain." So Hippocrates is saying, even in the setting of unrelenting pain, I'm not going to let a patient take their own life. The question I ask them is why? Well, it turns out that Hippocrates was a Pythagorean. And the Pythagoreans said human life was a gift from the gods. It was supposed to be held and defended. So for the physician to aid in the assistance of a physician-assisted suicide would be to violate that sacred trust the gods had given to the physician, because there's something special about that individual patient. So here we see the sort of worldview behind them, where Plato was looking for the welfare of the collective. Hippocrates was looking out for the well-being of that individual patient. We see this in precepts. He talks about his love for the patient. "For if love of men is present, love of the art is also present." So here we see these two worldviews as sort of applies to medicine. On one hand, we have Plato, where the physician's looking out for the good of the collective, and those that are a burden on society are killed or let die. To the other side, we have Hippocrates that cares about the individual patient. And it's sort of like there's a compass. Instead of a north and a south, there's an H and a P. So there's the needle starts pointing towards P, and that was sort of the common for ancient Greece. And you can think of free market forces. If you were a patient that was getting up in age, who would you go see? Plato's physician or the Hippocratic physician? You know, if your knees hurt and your hips hurt and your back hurts and your neck hurts, and you're going to go see the Hippocratic physician. I mean, because Plato's going to say you're a burden on society, we'll kill you or let you die. So patients start to gravitate over towards the Hippocratic physician because they want to see a physician that cares about them as an individual. And that's really what this healthcare debate is about. is the nature of the patient-physician relationship. And in a little larger context, what's happening in culture today is really about what it means to be an American citizen. The relationship between we the people and our government. It's almost the same thing, just slightly different orders of magnitude. So this needle swings from P over towards H, and it stays there for about 2,000 years. Here we see in the 14th century a Christianized version of the Hippocratic Oath. Because you think of Christian theology, match Pythagorean theology. Christian theology, Christian worldview, we believe that human life is a gift from God. And St. Augustine, the Imago Dei, we're created in the image of God. There's something special about each person. And as a Christian physician, as a Hippocratic physician, I want to take care of each individual patient because there's something special about them. So this needle stays pointing towards H up until the late 1800s. And in the writings of Friedrich Nietzsche, it's very interesting to see that he talks specifically about the role of the physician. In Twilight of the Idols, section 36, he talks about the moral code for the physician. Now listen for patterns in thought. The invalid, Nietzsche states, is a parasite on society. In a certain state, it is indecent to go on living. To vegetate down in cowardly dependence on physicians and medications after the meaning of life, even the right to life has been lost. Now this ought to entail a profound contempt of society. Physicians, in their turn, ought to be the communicators of this contempt. Not prescriptions, but every day a fresh dose of disgust for their patients. To create a new responsibility, that of the physician, in which the highest interest of life, or the ascending life, I'll pause there for a second. The ascending life, when you read Nietzsche, is the young, the strong, the fit, those that are moving forward, those that have power. You talk about or read about Nietzsche's will to power. That's where it comes from. He goes on. He says, this demands the most ruthless suppression and sequestration of degenerating life. Get a little time out. What's degenerating life? Well, it's the sick, it's the infirm, the weak, those that are called burden on society. So he goes on, for example, in determining the right to reproduce, the right to be born, in fact, even the right to live. So here in the writings of Nietzsche, we find thinking is very, very similar to Plato. And we start to see this needle swing back towards P. And as it turns out, following the writings of Nietzsche, we see the rise of the Third Reich. Behind me, we see a picture of the Dachau hypothermia experiments. These experiments, they take their subject, immerse them in ice water, nearly freeze them to death, and then rewarm them using various methods, supposedly to learn how to rewarm down pilots. So sometimes they put them under scalding lamps and burn their skin, or stick tubes down through their mouth and esophagus and pour hot water and scald their stomach, or up through their rectum and scald their colon. Sometimes they had opened their abdominal cavity and put in scalding water, or drop them in vats of hot oil. And if they were to survive, they'd be nearly refrozen and put through the torture all over again. And sadly, physicians were part of this. So following World War II, we see the Geneva Convention. Part of the Geneva Convention specifically tried to take this needle and pull it back to H. It tried to reorient medical ethics to its Hippocratic roots. Since then, what we're really seeing today is a swing of this needle, a piece at a time, back towards P. And really this whole healthcare debate is about this needle sort of fixed midline. Now what we have to decide as a culture, do we want to pull the needle back towards H, or let the needle swing on towards P? And as we start to move into policy, we'll start to see that. So how have we started to reverse our Hippocratic roots? To begin with, it's the Geneva Convention itself. In 1949, the Geneva Convention tried to pull the needle back towards H, but it didn't include an oath. It was a list of standards open to revision, and revision is what we're seeing. In 1960, the World Medical Association changes the wording of the Geneva Convention. Instead of life being sacred from conception, now it's special from its, quote, beginning. and we can start to debate when the beginning of human life is. 1973, we see the legalization of abortion. 1985, we see Peter Singer write the book, Should the Baby Live? Now let me read you part of this book and listen for patterns in thought. Quote, we think that some infants with severe disabilities should be killed. This recommendation may cause particular offense to readers who are themselves born with disabilities. Note this next phrase, perhaps even the same disabilities we're discussing. So Singer is saying there's people out there reading his books, listening to his talks, so they can engage with them mentally. He said perhaps they shouldn't even been allowed to live because they were born with a disability that was a burden on society. It was expensive. So we're starting to see the thinking of Plato come through here. 1994, Peter Singer writes another book, Rethinking Life and Death. This was the book that really sort of animated me when I got sort of invested in this whole medical ethics and culture back in the mid-1990s. Quote, there remains, however, the lack of a clear boundary between the newborn infant, who is clearly not a person in the ethically relevant sense, according to the Singer, and the young child who is. In our book, Should the Baby Live, my colleague Helga Kusa and I suggest a period of 28 days after birth that might be allowed before the infant is accepted as having the same right to life as others. He's talking about infanticide. This is clearly before the infant could have a sense of its own existence over time and allow a couple to decide that it is better not to continue a life that has begun very badly. Reminds me of the 1940s, of lives that are not worth living. So here we start to see these patterns in thought as we see this needle swing back towards Peter. 1997, physician-assisted suicide is legalized in Oregon. 1999, Princeton University appoints Peter Singer to its very prestigious chair of bioethics. 2008, the Oregon Health Plan refuses Barbara Wagner chemotherapy and instead offers to pay for physician-assisted suicide. I'm going to just pause for a second here. How many have heard of the Barbara Wagner story? Those that have maybe heard me talk before. Barbara Wagner was a 64-year-old gal, and she lived in Oregon, didn't have insurance, and the state of Oregon, like every state, was trying to figure out what to do about its uninsured. So they came up with a state-run program, the Oregon Health Plan, to provide insurance for the uninsured, which one could understand is something that we all would like to do. We all want to see our fellow Americans have access to health care. So what happened for Barbara, she had recurrent lung cancer. Went to see her oncologist. He recommended treatment with Tarceva. It's a relatively new chemotherapy. She went to get it, and turns out she found out she couldn't. So she instead got this letter from the state of Oregon saying, we're not going to pay for your chemotherapy, but we will pay for physician-assisted suicide. There's a remarkable video where this reporter goes and talks to some of the leaders of the Oregon Health Plan. They said, we're running out of money. We have to decide who gets what. So they said, chemotherapy is $4,000 a month. Physician-assisted suicide has a one-time cost of $100. And it's amazing because if you watch this video, and it's on my website, physiciansforreform.org. But Barbara is sitting in her chair, holding her dog. There's a kitchen in the background. Looks like she's ready to go start making cookies. So she's a viable 64-year-old gal. In the interview, she said, I'm not ready to die. She said, I can't believe it. They're willing to pay for me to die, but not pay for me to live. So really it comes down to government compassion. Sounds so noble. But in the end, whoever pays holds the power to choose. So we all want health care. I mean, I do, and I think everybody in the room does, and we all want our fellow Americans to have it. So there's this natural sort of yearning to say, boy, if the government can do that, man, that sounds great. Problem is the government's broke. Remember that first slide we looked at? $15.6 trillion in debt, looking at soon paying $1 trillion a year just in interest on the debt. State governments are broke and the federal government's broke. So if we give Washington all this power to, quote, be compassionate, it's not going to work. So just the health care bill itself, when President Obama first talked about this legislation, do you remember he said it's going to, quote, reduce the deficit by $140 billion a year? Well, it turns out that was all cookbooks. That was a shell game. They were hiding the money. The CBO just released a report. Instead of the bill costing about $940 billion, which is what President Obama initially said it would cost, that has been revised upwards now to $1.76 trillion. The cost of the bill has almost doubled since it was introduced, simply because they used so many accounting gimmicks to tell the public that it was going to reduce the deficit if it got passed. It's actually, by the time the whole thing gets accounted for, going to cost on the order of $2.5 trillion, which means it's going to significantly expand government expense in addition to the $15.6 trillion that we already have. So the government's going to have to start to limit expenses somehow, just the way Oregon did with Barbara Wagner. January 31st, 2009, the National Institute of Health Director of Bioethics wrote a paper in a very prestigious journal, The Lancet, and he introduces something called the Complete Lives System. Now this turns out to be a very important paper, and let me read you just a little piece of it here. Consideration of the importance of the Complete Lives System also supports modifying the youngest first principle. I'm going to take a few timeouts here as we go through this. What's the youngest first principle? Well, it's in Western culture, we believe there's something special about our kids. You know, if a house is burning, get the women or get the kids out of the bedrooms. If a ship is going down, get women and children off board. You know, the future of a culture lies in the minds of its youth. There's something special about our kids, and that we've believed that for centuries. But he's saying we need to start to modify this youngest first principle by prioritizing adolescents and young adults over infants. Now, why would he want to do this? Adolescents, he says, have already received substantial education and parental care, investments that are going to be wasted without a complete life. So he says, we really haven't invested anything in our infants, so let's not give them priority. But by the time people have reached adolescence and young adulthood, we've invested a lot as a culture in them, so we should start to prioritize them. Said infants, by contrast, have not yet received these investments. When implemented, the Complete Lives System produces a priority curve on which the individuals between the ages roughly 15 and 40 years get the most substantial chance, time out again here, the most substantial chance of what? Well, the paper is specifically written about what to do with medical procedures in an age of scarce resources. So if we don't have enough money to pay for everything for everybody, which we're getting to, who gets what? That's what this paper is dealing with, okay? So he says we need to produce a priority curve on which individuals between the ages of 15 and 40 get the most substantial chance of a medically necessary procedure in the age of scarce resources. Whereas the youngest and the oldest people, well, they get chances that are somewhat attenuated. All right? Unlike allocation by sex or race, allocation by age, according to this writer, is not discrimination. Treating 65-year-olds differently because of stereotypes, now that would be ageist, and we can't be ageist. But treating them differently because they have already had more life years is not. Now, who was this? Well, it's Ezekiel Emanuel. How many have heard of Ezekiel Emanuel?
Ron Emanuel's brother.
Yeah.
And he's a doctor, right?
Yeah, he's an MD, PhD. He's a White House healthcare policy advisor for the development of the Patient Protection and Affordable Care Act. And as you mentioned, he's the brother of Rahm Emanuel, the former White House Chief of Staff. So this is a very well-connected individual. This isn't some 1960s Berkeley radical that just kind of wandered off and you never heard of him again.
And how
This-
old is he?
He's about 60, but he's in a different spot than the rest of us. So he'll be taken care of just fine. So this next slide comes directly out of that paper, all right? So here's what you see in this paper. This is age at the bottom. This is probability of receiving an intervention. Now think about patterns and thought. What happens here, down near birth? Now if you need something, there's not much of a chance you're going to get it. Kind of sounds like Plato, or Nietzsche, or Singer. All right, but by the time you hit the age 15, you get a substantial chance of being treated medically up until you hit about the age 55. Now what happens after the age 55? The bodies just don't work as well as they used to. Since I do hospital medicine, the majority of my patients are over 55, which also means that's when healthcare starts to get expensive. Now, if you're going to cut $500 billion for Medicare, how do you do that? Right there, right there. So I can cut $500 billion from Medicare overnight. I mean, you just get rid of chemotherapy, like Barbara Wagner, or cardiac surgery, or orthopedics, hips, knees. So there's a way to drastically reduce the cost of Medicare. And he's telling you philosophically how he plans to do it. Yeah, we can reduce the cost of health care. But the question is that as a culture, the road we want to travel? And as a Hippocratic physician, I look at this graph, I say, that's not Hippocrates speaking, that's Plato. Because what you're seeing is we're treating those that are productive, those that are moving culture forward. So what we're seeing is a kind of a transfer of power, a fundamental remaking of what it means to be an American, where our government is starting to look at what's good for society rather than what's good for the individual. America was founded on the concept that individuals, under the rule of law, chose people from amongst themselves to go to government to serve under the rule of law and then return to live among the people. America was never intended to be this aristocracy of a permanent ruling class that would somehow use their wits to tell we the people how we should live, what we should do, and how we should select out those that are good for society at the expense of infants and the elderly. That's not the America our founding fathers had envisioned. But that's the fundamental transformation of culture that we're facing today. And this is how it applies to medicine. It also applies to education, to the Supreme Court, to the legal system as a whole, to foreign policy. Tonight we're just looking at healthcare. So to keep moving, March 23rd, 2010, President Obama signs the Patient Protection Affordable Care Act. Now, we can go through this bill. It's 2,700 pages, and my goodness, I've sat through lectures, and it just about either puts you to sleep or you leave with a severe, severe headache. I'm just going to look at a couple sections, not to go through all the detail, but to show you patterns and thought. And in some ways, people wonder why I spend so much time on history and philosophy. But policy is derived from the worldview behind it. Once you understand the worldview driving policy, you can see where it's going. Now I'll ask you to look at these couple sections of the healthcare bill with the worldview of Plato and Hippocrates in mind. Section 3007, the value-based payment modifier. These first four words scare me to death. The secretary shall establish. Now, the legislation, as we talked about before, doesn't really say what's going to happen in medicine. This is how the bill is filled. What sentence is like this: the secretary shall establish. An unelected, unaccountable individual shall establish a payment modifier. All right, here, well, let me read this through you once first, and then we'll go back and take it a line at a time. The Secretary shall establish a payment modifier that provides for a differential payment to a physician or group of physicians based on the quality of care furnished compared to cost. Now, in some ways, that doesn't sound so bad. So the Secretary is going to do something and supposedly going to help the quality of care and do something about cost. Well, as a physician, I want quality care, and I want to keep costs down. So it sounds like these are good things. But when we back up and go through it more slowly, we find out that it means something very, very different than what it appears. So the Secretary shall establish a payment modifier. Well, what's a payment modifier? It means that this individual can reduce the reimbursement to a physician at his or her own discretion. Okay, they now have that authority. So before I get to the rest of it, just to let you know a little bit about physician reimbursement and why those moving on to Medicare are having trouble finding physicians. It'd be easier to think about it if you're thinking about it in terms of a contractor, somebody that builds houses. Now, back when we were building houses, an average contractor might charge cost plus 12%. So you go and say, I want this $100,000 home built. And the contractor said, well, I'll charge you cost plus 12%. So if it costs me $100,000 to buy all the materials and hire the electrician and the plumber, and so I'll add 12% to that, so it'll cost you $112,000. So the contractor makes $12,000, and you get your $100,000 house. That's sort of like insurance, okay? The insurance will pay the cost to build the thing plus some profit. Medicare is approximately cost plus 0%, where you go to the contractor and he'll say, well, it's going to cost about $100,000, so I'll build it for you, but I'm not going to make anything. So, but I'm a really nice guy, so I'm going to build you this house anyway. And he might be a nice guy and put up 1 or 2 houses like that, but pretty quick he's going to be out of business because there's no revenue. There's no profit to him as a contractor. Medicaid is sort of like the contractor saying, I'm a really nice guy, I'm going to give you $10,000 to build your $100,000 home. So it'll only cost you $90,000. Now you might think that's a great deal. You get a $100,000 house for $90,000. But pretty quick that contractor is going to be out of business and not building homes for anyone. That's sort of Medicaid. Now let's back up. So when the Secretary shall establish this payment modifier, essentially that means the Secretary can withhold some of the reimbursement from the physician. So instead of breaking even, the physician is going to start to operate at a loss when they see a patient on Medicare. And that's why it's so hard for people entering Medicare to find a physician, because physicians can't stay in business operating at a loss. So it provides a patient modifier, provides a differential payment to a physician or group of physicians based on quality of care furnished compared to cost. So there's a pretty elaborate effort now to start to get all this data to see what individual physicians are doing in terms of their medical decision making. So that data goes to Washington. They can review it, and if the physician isn't following specified guidelines, now the Secretary of Health and Human Services could essentially put that physician out of business if they chose to practice another form of medicine. Now you combine that with Ezekiel Manuel's graph. So, and this is why government compassion sounds so noble, but whoever pays holds the power to choose. And it's changing what it means to be a physician. By extension, it changes the patient-physician relationship. Because if the physician is worried about staying in business because the government won't send them a check, if I don't take care of you the way they tell me to take care of you, if I want to stay in business, I'm going to do what the government says. It's no longer about us. Whether we worked out payments years gone by with chickens and corn, or some other arrangement that as an individual businessman I can work out with you. Now I'm beholden to the government to do what they say, otherwise the government puts me out of business. And that's why if you go back to that second slide we looked at, the physicians wanting to leave medicine, 43% of them, There's so much regulation now on the physician end of it, it's becoming very difficult to take care of patients the way we've always enjoyed taking care of them. Now, back to section 3007. So quality of care furnished compared to cost. Now it goes on, the term cost means expenditures per individual as what? Determined appropriate by the secretary. So the word cost means the secretary sets this number, which he or she feels is appropriate. And if the physician spends more than what the secretary says is appropriate, the secretary cannot pay the physician. To put that physician out of business, so the only physicians left are those that are willing to go along with what the Secretary of Health and Human Services wants them to do. So it's changing the nature of medicine. Let's look at the actual bill. This is the sort of the condensed version. I'm not going to read you the whole thing, but the pieces in red are all the transfer of power to the Secretary. Here, the Secretary shall establish, as established by the Secretary. The Secretary shall establish, as determined appropriate by the Secretary. Established by the Secretary, determined appropriate by the Secretary. The Secretary shall publish. The Secretary shall begin implementing. 21 times in these 2 pages, it transfers power to the Secretary of Health and Human Services. It doesn't tell you a lick about what's going to happen. All it does is shift power to an unelected, unaccountable bureaucrat. So let's look at one more section, section 3403. And how many people have heard of the IPAB, the Independent Payment Advisory Board? This is something you're going to be hearing a lot between now and November. This is, I think, by far the worst section of the bill. And by the time we get through understanding it, I always end up thinking, I can't believe this is happening in America. Let's run through it a piece at a time. So it says the purpose. And this is lifted directly out of the bill. I'm not changing the language to make it sound bad. Purpose. It is the purpose of this section to reduce the per capita rate of growth of Medicare spending. So the problem was the country's going broke, as we talked about to begin with, driven by Social Security, Medicare, Medicaid, and other federal expenditures. So they're trying to think, how do we reduce the cost of those programs? And this is their solution for Medicare. This is part of the legislation that's now law of the land. So they said, we don't trust Congress to start to limit spending. I mean, well, you know, have they limited spending in the last 10, 15 years? Back in the 90s, we had a bit of a boom, and it sort of looked like they did, but they really didn't cap spending. So they said, well, if Congress can't cap spending because they have to go back and face the voters, let's create this panel, this Independent Payment Advisory Board, these 15 individuals, so they can cap spending, but let's isolate them so they don't have to answer to the public. They said if we get 15 people in a room and give them power to cap spending, they can do it because they don't have to worry about public backlash. So that's really the thinking behind this board. Consists of 15 presidentially appointed independent experts. 2015, it gains authority to cap Medicare spending. Now let's spend time talking about this last sentence. The IPAB's recommendations become law unless overridden by 2 3/5 majority votes in the Senate and majority in the House as well. But why 2 votes? Well, because the IPAB is different from any other advisory board that works with Congress. Most advisory boards, and there's a bunch of them, and they come up hopefully with good ideas, some better than others, some not so good at all. And they recommend, they give advice to Congress. Say, here's our advice. Our board found this idea, here's our advice, put this into legislation. For that idea to become law, it needs to pass through the Senate and the House. It needs to get through the Senate with a 3/5 majority to overcome the filibuster. Until any bill gets to 60 votes, it can't pass the Senate. So it can't pass cloture. So, but this, the IPAB stands this principle on its head. For an IPAB's recommendation, let's say they say, you know, we're getting into really fiscally difficult times, saying no dialysis, no chemotherapy, and no casts, hips, or knees for anybody over 65. Say that's the recommendation. You know, that would cause a public uproar. I mean, seniors would go just absolutely ballistic. But let's follow what's happened and see how that plays out. This is the law of the land at the moment, okay? So the Congress has to vote twice on that recommendation. The first vote, they have to actually vote it down, otherwise it becomes law. Not that they give it to Congress and Congress has to pass it. It starts as essentially law unless it's voted down by at least a 3/5 vote. Well, in a case of a horrible recommendation like that, you know, there'd be 100 senators saying, hey, boy, this is a really, really bad idea. So we got 100 senators saying it's a horrible idea. Turns out it still becomes law unless there's a second vote. Now the second vote has to have cuts of equal or greater value. So we don't like these cuts, so unless Congress comes up with cuts that are equal or greater in value, that still becomes law. So unless Congress comes up with something even larger than the IPAB goes straight from its advisory board to becoming law. So essentially this transfers legislative authority from Congress to a 15-member panel. And I think about it, that reminds me of Stalinist Russia. That shouldn't be happening in America. But it is. This is currently the law of the land. Now you think about it, and this is actually really, really clever. Corrupt as all get out, but really clever. Because what does it do? It transfers power to this IPAB. Now the senators can come back and say, oh man, I really didn't like that idea. I did everything I could to vote it down. Keep me in office because I'm really looking out for you. Okay? So they can say, I really hated that idea. I'm really so sorry it got through. I tried to stop the thing. That's exactly what they intended. It excuses them from responsibility. So this 15-member panel can make these devastating cuts, and then our elected representatives can come back and say, man, I really didn't like that either. Let me go back to Washington so I can try and look out for you. But they're the ones that created this plan to absolve themselves of responsibility. And this just should not be happening in America. And now you think back to Plato in Ezekiel Emanuel's curve. So there is now a mechanism in place, legislatively, that's passed, signed into law, to enable that to happen. So it's interesting, in President Obama's budget is, I think, released back in February. He actually talked about the IPAB. And he said, quote, we need to strengthen the Independent Payment Advisory Board to reduce the long-term drivers of Medicare cost growth. So here there's conservatives screaming, this isn't even constitutional. We shouldn't have a 15-member panel controlling that much of the federal budget, and that could be potentially that devastating to seniors. President Obama's out there saying we need to give it more power. So there's two very, very different worldviews in terms of how we should move the country forward. And this is in his fiscal 2013 budget. So I get back to the slide. We're $15.6 trillion in debt. Is there another way forward? And as it turns out, that's what I've been traveling around the country trying to explain to people, is there is another set of ideas. Yeah, finding problems in healthcare is sort of like shooting fish in a barrel. I mean, there's a lot of problems in the healthcare system. Even I still work as a full-time physician. I see the problems in healthcare pretty much every day. So it's not that it's a perfect system. It needs to be fixed. We need to control cost, but not like that. So there's another way to do it. A friend of Herman Cain last summer asked me to write up a plan for U.S. healthcare reform. If we overturn Obamacare, what would the alternative look like? And I wrote, it needs to be a 3-part series. I've only got the first part out. I'm hoping to get the next one done in several weeks. But this is online. I sadly ran out of glossy copies. But you can download it for free on the website, Physicians for Reform. So it's a paper called Cutting the Gordian Knot. And in it, I lay out several principles. Let's see if I have any of these here, or I don't. So let me just read you a few of the principles. What President Obama and Congress did for healthcare reform was take all these ideas and put them into this 2,700-page piece of legislation. Prior to medicine, I used to be in electrical engineering. And any time I was given a complex system or a circuit board, I would never change 50 inputs all at once and have any hope of understanding what happened in terms of the change in outputs. I would change one piece at a time. Change one input, watch the outputs. Make your best guess at the next biggest problem, change the next input, watch the outputs. When you engage any complex system, that's the only way you're really going to fix it. Changing all the inputs at the same time is just going to lead to chaos. So I wrote out 5 guiding principles. Number 1, craft a series of reforms, each reform addressing one clearly identified problem in the current U.S. healthcare system. So take one problem, find one solution, and propose it. Don't propose 2,700 pages of changes. Then pass each reform separately. Number 3, write each bill using an understandable format and keep it to a reasonable length. Number 4, keep each bill clean, letting it pass or fail on its own merits. No pork, no payoffs. Number 5, make the final language available to the public for a week prior to voting. So what we need to do is start to get Congress to think in terms of actually solving the problem. Not political gain, not advancing a partisan agenda, but how do we actually fix the problem? At $15.6 trillion of debt, we have to fix these problems. If we don't fix these problems, we're going to be bankrupt. And we're going to cede sovereignty over our own budget to a world body. So then I went through and listed 17 specific reforms. I won't go through them all tonight. Maybe in a Q&A we can address some of them. But there is another way where you can take one problem at a time, and I find 17 of them. Pass one bill, one problem, keep it clean, no other agendas, and start to fix the problem. And if those of you want to help, there's a petition on the website that sort of lays out some of this thinking. You can go to the website physiciansforreform.org, and I'd be glad to have your support. And another thing you can do, and we have some books on the table up here, but for a donation of $20, that's my book I released several months ago. It's called The Battle for America's Soul: Healthcare, the Culture War, and the Future of Freedom. The first 3 chapters, I sort of discussed this background that we talked about with Plato and Hippocrates and what's really happening behind the healthcare reform effort. The center section of the book, I developed this concept of worldviews. Why is it the left really hates the right? Why is it the right can't understand the left? I mean, as we live in these two worlds where neither side can talk to each other, how did that happen? How did we get to these places where we have such radically different views of what's good? I mean, because those on the left that are advancing the Patient Protection Affordable Care Act genuinely believe that's good. And those of us that follow Hippocrates, or conservatives, we see something else as a very different definition of good. How can these groups get to a place where they can't understand each other? That's the second section, chapters 4 to 13. The last 4 chapters, I take the same battle of worldviews, I apply it to foreign policy, I apply it to the courts, I apply it to public education, and then postmodern politics. But if you want that book, Patsy will help you with that afterwards. So why don't I stop there? Sometimes I can keep talking and talking and talking, but what do you have for questions?
What's your view where you get now, you get your one time a year medical checkup free? I mean, it's paid for. What's your view on that?
Well, I think an annual exam is a good idea. So the thing that makes me nervous about free
Well, I don't mean it's free, I mean our
Mhm.
insurance pays
Mhm.
for it altogether.
So in the series of proposals I have, I suggest changing insurance to sort of preventive medicine, which that would fall over, is reimbursed substantially more than some other things to help encourage people to come get there. Though it's interesting, when you reduce something to free, people don't appreciate it. So I think that there should be some sort of patient involvement. And there's a phrase, skin in the game. So where patients need to have something at stake with the physician. You know, I have something at stake because I need to stay in business. I want to provide a service. In every other place in the free market, when a patient or a customer comes, they're tempted to ask better questions if they have something in it. So we can see that's another idea that comes out with a healthcare savings account. So, and it's more for a younger, healthier group of people, not folks on Medicare. By the time you get to Medicare age, you tend to have more problems, tend to need more insurance, tend to need more health care. So the HSA system doesn't work well for that age group. But for the younger age group, if they can purchase a lower cost, higher deductible plan, and then put some of their own money pre-tax into a savings deposit, so when they get to the physician, they pay for a portion of it themselves. But when you pay for a portion of it yourself, you start to ask two questions. How much does it cost? And do I need to have this test? Because what I find, especially in the emergency room, folks come in and they have a headache. They say, well, I want a CT, I'd like to see a neurologist, I'd like an MRI, and then I'd like to see a neurosurgeon. And sometimes I say, boy, I'm not sure we need all that. They say, well, I'm not paying for it. And then the next sentence is, and my brother's an attorney. So if I don't order everything that's being asked for, they threaten to sue me. And it doesn't cost me anything, so I go check, 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 check. And we order all of these studies, much of which isn't needed. But if patients could start to ask the question, do I need it and how much does it cost? Then it starts to make me think as a physician, well, do we need it? And then I have to start to be aware of cost. And I'm wondering off your initial question.
Well, the new care recommends, you know, the women all get a mammogram every year. And Medicare and your insurance pays for it. And then your blood work, say that you get, I'm thinking more along the line of blood work and things like that. They say you get now with your insurance paying for it, Medicare.
But, and I think people should get the preventive screenings and blood work. But it's interesting, when we don't have anybody pay for it but the government, do you remember, was it a year and a half ago, the government ran out of money and said, well, we don't think we should screen with mammograms over the age. They increased or changed the age from like 55 to 45, or I'd have to go back and look up the numbers. But they said, we didn't think it's worth it, so we're going to quit paying for it. So whenever the government tells you you're going to get it for free, that means they can decide that you don't need it anymore. When they run out of money, that's what they'll decide. That's what they have decided. So, and sadly, that's the way. What my series of reforms tries to do is shift that power back to the individual patient instead of we the people sending all our tax dollars to Washington, Washington spending it on who knows what, so that money is not left. And then they tell us when we want to go get something we need that we can't have it. That's what's happening with the system as it stands.
I went to an urgent care in Hickory. I had total knee replacement. And I had broke out in the hives right when I got to my daughter's house. I went to the urgent care over by Steinmore. They wouldn't take me when they found out I was on Medicare and I had Blue Cross insurance. They said, we can't do all that paperwork. So they said, go down to one on Springs Road. And there I was broken out in the hives, my lips were swelling, they wouldn't take me.
Well, a lot of it is because Medicare and Medicaid have gotten so abusive.
Yeah.
A lot of physicians don't want to deal with it. There's something, has anybody ever heard of a RAC audit? Well, it's worse than litigation. A RAC audit is where the government comes in and reviews charts. And they hire a separate business to come review the chart, and that business gets a portion of the, quote, inappropriate billing. So unannounced, they can walk in and look at all the medical records. If they find anything wrong with that medical record, they can levy enormous, enormous fines. So Hickory Cardiology went through it a couple years ago. They got accused of $364,000 worth of inappropriate Medicare billing. So that auditing company, the Recovery Audit Contractors, what RAC stands for, collected a percentage of that. And then it was up to the cardiologist to go back and defend the record. It took them a year, almost $100,000. And when they started to go through these charts, one of the things they were accused of is inappropriately doing this chemical stress test. Well, it turns out when they went and looked at the chart, the man had no legs. The auditors said they should have done a traditional stress test, but he had no legs. So they had to spend a year and $100,000 defending themselves against those kind of accusations. They finally got them overturned, but they had to go out and borrow the money to pay the government that $364,000.
And of course they don't get it back.
And they didn't get any of the interest back. And then, and it has gotten to a place that is, my old group got charged of $1.65 million of inappropriate Medicare billing. Even though the cost of Medicare, the reimbursement for Medicare, is putting many physicians out of business, then they're are being accused of this, and that's going to be expanded to Medicaid.
Why did they privatize the accounting system to overlook it? Why did they take it out of the agency itself?
Well, no, the thing is it wasn't the accounting part. I think I'm missing. What it is this contractor will go in and look at the records.
I mean, the contractor's a private contractor. Why
Yeah.
is that outside the system? That seems like that might be the problem.
Well, it is
Giving them the
because,
profit out of it.
well, yep, they get profit, but a lot of them are set up by senior political people.
Yeah.
So a lot of that money is being fed back to, sir.
Yes, I've got a question.
Yeah.
Forgive me for coming in late, I missed most of your section. But what's your point of view on alternative medicine versus traditional medicine?
That's kind of a big question. Generally speaking, alternative medicine does a lot of people some good, but a lot of alternative medicine isn't researched and documented, so it's hard for me to recommend it. If it gets to a point where some of it has the same level of scrutiny as traditional medicine, then most of the traditional physicians would be behind it. But I'd also, at the same time, using the HSA, where patients can put their own money to the side. Then if it's not covered by insurance, they can still use some of their pre-tax dollars to go purchase it. Let's say you have some sort of form of alternative medicine that you really like. You should be able to go get that. Not some government person telling us you can, no you can't. So if you can purchase it with your own money that you've set aside for your own health care, you should have that choice.
One other question.
Yeah.
Say, for example, if I was a patient in the hospital and I had a headache, why is it that I'm required by hospital staff or by hospital policy that I have to take their aspirin versus my own aspirin that I've just brought from home?
Well, actually, you can take the aspirin. What it is the physician...
But they won't let you.
I'm a hospital doc, and I do let my patients. So what you have to do is write, patient may take own meds. You have to show your meds to the pharmacy, and if the pharmacy can document that that medicine is what it is, then you can take your own meds. So it's possible.
They tell you to leave it at home when you're having surgery.
Right.
Yeah. Well,
Nobody
most of the
brings
time they
it
do,
back.
and it's mostly because it just is much easier for the system to work if the hospital. A lot of it gets down to litigation, because if patients come in and say they're taking one thing, but they're taking something else, and there's an adverse outcome, then the lawyer comes back and says, well, why was that patient on this medicine? And it doesn't work saying, well, I thought he was taking something else.
Okay. No, but what I mean is specifically when your medication specifies that this is a certain medicine that's been issued by a pharmacy, but you're bringing it from home, going into the hospital, but the hospital says you have to buy it from them.
I'm a
And you
hospital.
can't take, and you just can't take your own
Yeah.
medication. And it's the same medication, the same name.
Yeah, I'm a hospital physician. I think you probably missed that part, and I'm still working full-time. And I let patients take their own medication. So it just has to go to the pharmacy to be approved. So, but I think most of it is in terms of it just, if you had every patient taking their own meds, it just logistically gets to be very hard to keep the system moving.
You
Ma'am?
mentioned that with the new health care act, that the secretary would set the reimbursement rates. Who's setting the reimbursement rates for Medicare presently?
Well, there's a board that meets, I think it's called MedPAC, and there's a board that meets to kind of set rates, and some of the discussion ends up being, should we increase the reimbursement for primary care physicians, but to do that we have to decrease it for radiologists or cardiologists, and then there's a board that goes through and tries to adjust the rates, and they think, well, how much education did you need to do that given procedure, or how much expertise, or how much risk, and how much time? So there's a board that sits down and tries to do all that.
How big is this board? Is it all?
It's not very
private
big.
Positions?
There's working physicians on it. So it's not the IPAP. It's more of a working physician. It's not real big, but it's more accessible than the IPAP, and it has working physicians on it. So I'm not sure it's a great way to do it, but it's hard to think of unless I can think of a better way to do something, I try and limit my critique. So, and I can't come up with a better way to regulate Medicare reimbursement. Because I don't know who else to trust it with, because somebody has to make that decision. So yeah, I have a lot of beefs with the system, but that's not one of them. So, sir.
I'm probably the most conservative person here in the room. Can you quote any place in the Constitution of the United States that says the U.S. government should be involved in the health care of individual people at all?
Yeah, and it's not. So that's just, it really comes from post-World War II. It's kind of how we got into this whole mess. When there is some wage freezes, where the government said you couldn't raise wages, so companies started to offer health insurance as a way to artificially boost wages to get better workers. And because they did that, it got to be so it wasn't taxed and paid for the pre-tax dollar, and then 1965, Medicare, Medicaid, and we just sort of got into this long after the Constitution. But
Nobody brought a case against the government such as they're doing now with this.
Yeah, because this is a whole, well, that, I mean, there's been
This is
some,
just an advancement on what we've already been in.
but it's more than just advancement. It's almost, I mean, that was
Morphing into socialism, 100%.
expansive as it was, but this is almost a whole order of magnitude different. I mean, in terms of the control, though it was there, Medicare, Medicaid, there's a lot of government control and regulation, which there has to be. In a sense, if you're going to give the government, you know, $427 billion a year to run Medicaid, and another $500 billion a year to run Medicare, there has to be oversight. I mean, the money has to be looked at, so there has to be regulation. And that's where you start down this path of the more you spend, the more you regulate, the harder it is, the less efficient it becomes. It's very interesting. I was doing a town hall similar to this in Raleigh a year and a half, 2 years ago. And there is a family practice physician as part of the board I was moderating. There's a 3-person board. He decided to give up Medicare, Medicaid, and all insurance. And it's interesting, he said the average family practice physician hires, I think, 4 staff for every 1 physician because there's so much paperwork. When he got rid of all the paperwork and all the traditional insurance, Medicare, Medicaid, he now has 3 physicians for every 1 staff. So he tripled his efficiency. The average family practice physician collects about 65% of what they bill. And they pay about 60% of that in overhead. Because he's fee-for-service, he collects about 100% of what he bills and pays about 25% of it in overhead. So he's tripled his efficiency. So he spends more time with patients, he charges patients less, and has better outcomes because he can practice medicine. He gets rid of all these regulations, because if you don't take federal dollars, you can escape federal regulation. And that's part of the reason physicians are getting out of Medicare, because these RAC audits are so abusive. It's hard for me in the time we have to describe how abusive they are. They're worse than just frivolous lawsuits. But by escaping all that, he's practiced so much more efficient medicine that people with Medicare, Medicaid, and insurance will come and pay out of pocket to see him because they get more time and have better outcomes. They feel like they're treated like patients, not numbers.
Well, you're, for most of us who are 65 plus, we've been paying in for a long time in taxes, one way or another. We're among a few that have or should expect some return.
And there should be.
But does your book explain the fact that if we were not involved in this in any way, shape, or fashion, we could get more for our dollar and better health care?
The book talks about the world view piece of it. What's the 30,000-foot view? It doesn't get into the detailed policy. Papers like this, I get into the detailed policy stuff. But the book is more what it means to be a patient, what it means to be a physician, how did we get here as a culture, how does it apply to medication, and for education and foreign policy and politics.
What do you think of the VA system? I know some people think that that's a good model for national system.
Yeah, I worked in the VA system some through training. It's a tough question because it's a tough answer. Because we absolutely need a great VA system. I'm a huge supporter of the vets. But the way it's constructed, it's sort of what happens sometimes when you get to a socialized system. The efficiencies just start to break down. And I hear more patients trying to escape the VA to get to see me outside the VA. And I'm glad it's there, and in a lot of ways they try and do a great job. But the VA system has a lot of challenges, I'm afraid. So, ma'am.
Well, I have two to add to the VA. My husband, they furnish all his medication, anything that he needed to keep him alive. But we also had a Medicare and a supplement that he went to the outside doctors and then just went for his physical periodically at the VA. So I don't know if,
Yeah, I'm glad it's there, and to be honest, I haven't spent a lot of time researching the VA system to find out where it's breaking down, just because I see so many VA patients come and hear stories and physicians that have been there that think there's a lot of room for improvement. So, sir.
Do you see an opportunity where doctors themselves can begin to make changes by opting out, like the one you talked about, of the Medicare, Medicaid, and start working back the old way where we can then go to them without any involvement?
Yeah, there's a huge amount of interest in that.
Because to me, that could upset their whole apple cart if the doctors would band together and go back to practicing real medicine and abandoning the federal government.
And the fear is that the government's not going to give a medical license to doctors that do that.
Too much control.
What about skipping all of insurance, every kind of insurance?
Well, yeah, that's what Dr. Forrest does, and he's done extremely well using that model. And that's why there's so much interest in pursuing that model. But if too many physicians start to do it, there's concern the government won't give us licenses. So they're going to say to get a medical license, you have to.
But isn't
Be
a
under their
license a
control.
state issue? And can't the state stand up and say, we are licensed these people in this state?
Depends on the state.
Yeah, there was a wrong way.
How would you afford
But
it?
then the state may, because, well, just look at Medicaid, for example, North Carolina Medicaid. North Carolina spends about $10 billion a year on Medicaid. Back under the stimulus program, the federal government had what they call the 75% FMAP, Federal Matching Assistance Percentage. So that means the federal government sent us 75% of what we spent on Medicaid. Spent $10 billion, they sent us $7.5 billion. So then when the stimulus money ran out, they dropped that FMAP from 75 to 65%. So they sent North Carolina $6.5 billion, which left North Carolina a $1 billion shortfall. So then the state has to try and figure out, well, what can it do to get that money back? And the tough part is, even though the states are separate, they get so much federal money coming in, and that federal money's tied, has a lot of strings attached. So if the state wants to, like in the Patient Protection Affordable Care Act, one of the provisions, I don't want to bore you all with policy detail, but there's something called the maintenance of effort, the MOE provision. The MOE provision essentially tells states that if they start to downsize their Medicaid program, they lose all federal funding. So right now, when North Carolina went from $7.5 billion of federal aid to $6.5 billion of federal aid, in a normal business model, a normal business would say, we've dropped our revenue by 10%, so let's cut back on service until we can kind of balance the books. But the federal government said if you cut back on service, you're going to lose all your money. So then the state is left with this overly expanded Medicaid program that it now can no longer afford. And the states really, that's what this whole 10th Amendment, the state suits, and that was the kind of the fourth section of hearings in the federal court case, just a week and a half ago, was, does the federal government have the right to tell states what they have to do? When they take state money, because the money comes from we the people. We the people send the money to Washington. Then when Washington sends it back to the states and to we the people, they have power. So,
My sister, first of the year, her doctor told her that he would have to have $25,000 a year to stay her doctor. And I took her to my doctor, and my doctor said she couldn't take no more Medicaid. She has kidney failure, heart problems, high blood pressure, and she has to go to a practitioner.
a nurse practitioner, yeah. And that's the
It's
other.
already.
That's the other thing that we're starting to see is these, because as physician reimbursement has been decreased, physicians are going out of business. Both cardiology groups in Hickory just went out of business. I don't know if you all knew that. So now they're employed by hospitals. Mile Group, Hickory Acute Care, went out of business because of low Medicare reimbursement. So now I'm a hospital employee. I work for a great hospital. They have a great administration. They treat me very well. I'm free to take care of my patients the best I can.
Where do you work?
At Caldwell. But the problem is more and more physicians are going out of business. They're being pushed into these other groups, and they're losing their ability to adjust.
I just wanted, if you'll help me with that, what I have been learning about, and if it's correct, with my understanding. And that's about the two organizations that were put into one of the stimulus bills, the Federal Coordinator Group, that has a long name, the Federal Coordinating Council for Comparative Effective Research, and that's the 15 members. And their whole thing is to get the cost of the treatment and divide it by the years that is a benefit to the patient. Is that right? Is that part of it?
You're almost right. You're
Okay.
missing a couple things, but
All
you're
right.
close.
And then the other organization was the National Coordinator for Health Information Technology. And that one is at the time and place of treatment that you will get your diagnosis. What my question is then, if that's kind of right, I understand that the doctor with his handheld device at time and place, that he punches and everything into his computer, pushes send, and it goes to the coordinator. And the coordinator then will come back at time and place and give the doctor the order or the diagnosis. And that information has all come from those 15 men, from the, well, from that iPad
yeah,
board.
You're very close. You're mixing 2 or 3 different groups, but
Oh, okay.
But okay.
Well, because that's what I wanted to get straight.
Yeah.
If there's 2 organizations or not.
oh, there's scores of
Okay. These are the 2 that I picked up from one of the stimulus bills.
yeah.
Okay. And then what I want to know, is it January 2013 that this is going to take effect? And I understand it's by 2014 that push the button, send, and is that?
Yeah,
Is
boy,
there a date?
You brought up a whole bunch of different things.
Yeah.
Yeah.
Because I tell everybody, and I want to be sure I'm right.
No, you're very close. What it was in the stimulus bill, there were a couple different panels set up. One was health information technology. In this coordination, you had the names there. The names were right. So.
Yeah. The Federal Coordinating Council for Comparative Effective Research.
Yeah, so the Federal Coordinating Council for Comparative Effectiveness Research, and then the other one was?
Then it's the National Coordinator for the Health Information Technology.
Yeah, then the National Coordinator for Health Information Technology. Well, so was an idea that there was going to be a panel set up for comparative effectiveness research. And as a physician, I like to compare things. I like them to be effective, and I like them to be researched. Kind of gets back to your holistic medicine question. I like research. Show me the research, and I feel more comfortable. So there's this panel set up for comparative effectiveness research, but what they're really doing, and they put that in combination with this health information technology. So when the physician now, and my parents are saying the same thing when they go see their physician, and I'm in the hospital, so it's a little different for me. But they said so much of the time the physician spends more time on the computer than they do actually taking care of the patient. And it drives patients crazy. Well, it drives us crazy too. And then, so they're being forced into this computerized network so that information can go to a database to be analyzed. It's not to the point where it's at the point of service where somebody up there looks at it and, I mean, there's 700,000 physicians and there's not 700,000.
Because I thought they just used the formula, and not knowing how old I was and whatever, that they would say, okay, you get this or that, or you don't get this.
Well, there are guidelines that are being developed where that fits into, and then there's certain medications that are allowed, certain things that aren't. And
Okay, so it's not an instant answer that comes back.
No.
So time and place is not correct.
no, well,
Time and place of treatment.
no, the language is in the bill. Time and place is the language, but it's not practically happening today. So
That's what I win.
Yeah. Well, I'm not sure that it ever will, because to think that we could create a system that could do that is near impossible. But what they're doing is they come back and they're auditing charts later. And if there's anything in the audit that steps outside guidelines, you know, the physician can get severely punished, to the point of putting them out of business. So there's a lot of fear on the part of physicians to keep practice, to not to violate these guidelines.
Can they force you to come back if you decide to leave your practice? Can they force you to come back and serve them and see patients?
Not yet.
Okay.
I guess there's always a gulag, but
The doctors that go to the, I'm going to say, go to the hospital to do their paperwork for them and this sort of thing. Now, will they be governed by everything, by the hospital? What they can do
well, it's
and
kind of
what
like
they can't, what they can't treat?
Yeah, because I'm a hospital physician. So because the margin is so slim, a lot of physicians don't do both clinic and hospital medicine. So I just stay in the hospital and they just stay in their clinic. But yeah, I'm governed by all kinds of rules in the hospital.
So
when somebody has to leave, who I get to keep. And if you get to the hospital, you'll probably hear somebody talk to you about they don't meet criteria. we have all these criteria of who gets to stay, who has to leave. And then there's more criteria of when this has to be done, what test has to be ordered, what test shouldn't be ordered.
Yeah, like my doctor, I was going every 3 months, now it's every 4 months, so that's coming from the hospital then.
Probably not the hospital. And I'm not sure on that particular one, whether it's just a scheduling issue where they just couldn't manage that volume, so they're starting to space patients out a little further. Some of it can be coming from Medicare, where they won't pay for things more than once a year, twice a year, 3 times a year.
That could be, yeah.
So and if the physician won't get reimbursed from Medicare to do something 4 times a year.
But the hospital can tell them what they can do and what they can't do?
If the hospital owns the practice, they can. Because there are a lot of hospitals that own practices.
Oh.
Because the physicians are going out of business. They're being purchased by hospitals. So the hospital now has ownership of that physician. So and they look at cash flow. And if there's not cash flow, the hospital adjusts that physician to...
They say you can't be under our umbrella anymore, you'll have to go someplace else.
If you're going to work for us, this is what we need you to do.
Because we've lost some, yeah.
I think one more question, and then if people want to get the books, and then individually chat with you, perhaps.
Yeah.
Any physicians in the area selling like their own insurance? My best friend in Tulsa, there's a doctor there, I think it's like $800 a year, and he'll come out to the house.
There's starting to be some models that do that. There's a couple of physicians. Some of the models I think are pretty good. Dr. Forrest, I think, had a great model. Some of the local docs doing it, I don't think they're off on the right foot. I think their business will end up
Guess I'll have to
going
go see
under.
the vet.
Yeah. So,
we got one here tonight. Nicole has a question.
Yeah.
I was just wondering if you could go over some of the details of the Supreme Court case and what that could potentially do to help the healthcare reform bill, and what they are going over in that case, because it's my understanding it's I'm mainly hearing about the individual mandate that they're reviewing that, but what all are they reviewing and what will that do?
Yeah, it was a remarkable case, and I was working, so I didn't get to listen to the whole thing. But it's highly unusual to have 3 days of hearings. I mean, that was enormously unusual, because this is a monumental decision. So the first day was a question of jurisdiction. I mean, since it hasn't been implemented, then supposedly there really isn't damage, and was it a tax or not a tax, and is there standing for the suit to even be heard? So the first day was all this legal back and forth of should we even bother listening to this case. So because the case went on, I think most of the Supreme Court justices said, it's a big deal, we need to deal with it. So that was the first day. The second day started to deal with the individual mandate and the constitutionality. And the question is, and the one side argued, the government doesn't have power to force you by the virtue of being an American to buy any private product. I mean, that's an expansion of the Commerce Clause that we've never seen before. Just because you're an American, the government shouldn't be able to come tell you you have to buy something. That was the state argument. The government argument was because people need health care, they're already in the market. It's just a matter of whether or not they're paying for it. So that was how they tried to position it, saying because everybody uses health care, everybody should be paying for it. So they're already in the market, just they're not paying for it. So it's really not an expansion of the Commerce Clause. So that was sort of that sort of back and forth. And then on the last day, there is a question on the Medicaid dollars. Does the federal government, if it collects money, Medicaid money from state taxes, does it violate the 10th Amendment? Does it violate a state's rights? For essentially what's, and this is a very biased phrase, and I try and be pretty objective, but it is objective. Still biased though. This is really federally mandated bankruptcy of the states is really what it gets down to. Because I have data, if you go to the website, And you can download this paper. At the end of the paper, I have Medicaid data from several different states, including North Carolina. So I used 2009 inflation-adjusted dollars per capita spending, not per Medicaid patient, but for North Carolina resident. Back in 1989, total state expenditures were $2,778 per person. This is stuff you can look up. Medicaid was $272 per person. 2009, that same per capita inflation-adjusted dollar expanded 314% to $1,125. If you look at the other expenditures, state expenditures grew by 63% of an inflation-adjusted dollar. If you don't adjust for inflation, it's hugely more than that. Medicaid expanded by 314%, elementary secondary education by 20%, higher education 18%, transportation 29%. So what happens is Medicaid has consumed the entire state budget to where the state can't spend on education and roads and all these other things the state needs. But now the state can't reduce the size of its Medicaid budget because the feds say that's illegal. Otherwise they lose, $6.5 billion, which the state can't afford. So it's almost turned into the federally mandated bankruptcy of states.
If the court takes the most conservative ruling possible, would that potentially kick out the whole bill or just pieces of it?
Yeah, and that was the fourth section. Well, technically the state piece was the fourth, but the other section is something called severability. Have most of you heard about severability? So severability, most legislation that's put through has something called a severability clause in it. Meaning if parts of the bill get struck down, it's severable. It can be severed or separated, and the rest of the bill stands. Initially, the Patient Protection Affordable Care Act had a severability clause in it. So if the individual mandate was pulled out, the rest of the bill stood. They took that out. So they didn't have a severability clause. At that point, it means the bill stands and falls together. So without a severability clause, if the individual mandate goes, technically the entire bill should go with it because the whole bill is unconstitutional. If they had left the severability clause in, they'd say if the mandate is unconstitutional, you just pull out that little piece and the rest of it stands. So the third portion of the argument was, is the mandate severable? And what it gets down to is a question of the mandate. Is it constitutional? Can the government force you to buy something? If it's severable, if they sort of take a conservative view on the first portion, saying that's not constitutional, but they say, well, let's kind of fudge the severability thing, but let the rest of the bill stand. The problem with that is there's no funding to make it work. If you remove the mandate, the entire bill collapses because of its financial structure. So that's really sort of the dilemma. Even if they pull out that one little piece, the government was arguing that it is severable, there'll be no financial support for the health care bill. So the whole thing will collapse financially. And that's what we're going to see. So I'm trying not to guess at which way it's going to go. My position is, no matter which way the Supreme Court rules, it's going to be devastating for patients, especially seniors. So I have to lay out another way forward, and we, the people, can choose our representatives to repeal the thing and replace it. So that's really my position. It doesn't matter what the Supreme Court says, it's devastating, but we have to fix the system. So.
Is that
Under Obamacare.
Yeah, and that's what.
That's what you want us to give the congressman, I mean, to
Yeah.
remind them of it?
Yeah, if you want to go to the website and send that to.
Does everybody have to pay insurance under Obamacare, or does people get it free?
It depends whether or not you get a waiver. So,
But there was 1,200 of them?
yeah, there's, so technically, everybody had to buy. That was the plan. But then there's so many businesses.
Everybody said we're gonna get free insurance.
Yeah, and,
That's all what I heard. I'm
Yeah,
sure they won't
it's-
find you if you don't.
yeah, you're going to get a fine unless there's a waiver. Well, thank you so much for your time, and I hope I didn't make things more confusing than not. But thanks so much for having me. Yeah, and if you want a book that's available up here, and Pat's so happy with it. Thanks again.